Okay, hold on one moment. Good evening, everybody. My name is Casey Swid. I'm the marketing manager here at Cell Science Systems. And tonight we have a great webinar scheduled for you. We have Dr. Tania Dempsey. Presenting tonight, just to give you a little information about her background. She founded Armonk Integrative Medicine in 2011 based on the philosophy of integrating traditional medicine and complementary therapies. She believes in the powerful partnership between physical and patient, creating the foundation for healing the mind, body, and soul, or in spirit. Dr. Dempsey combines primary care treatment and integrative medicine with expertise in thyroid dysfunction, hormonal imbalances, vitamin deficiencies, and food. Without further ado, I am going to present Dr. Dempsey. Dr.
Hi,
Dempsey,
thank you.
yours.
Yes, thank you. Thank you, Casey. Thanks for having me today. I'm really excited about this webinar today because we had so many questions after the last webinar, and I'm very interested in, allowing everyone to hear the answers. We've got some good data. We've got some good protocols to talk about. So, I'll get started. And my controls are not working.
Okay, let's see here. Okay, you should have control right now.
Yep, I think we're good. Okay. So there were basically, after the last webinar, there were basically 4 or 5 areas that were most commonly asked. Okay, there were areas that people were most interested in hearing more about, and I'm going to focus on that today. The areas include the ALCAT test in general. There were questions regarding gluten specifically, because I alluded to gluten a few times. People were interested in the more specifics about the rotation diet, diseases and conditions that would benefit from ALCAT testing and treatment, and lastly, I'm sorry, oh, I heard something. And lastly, the leaky gut protocol that I mentioned a few times. I think people are interested in, my the specific products that I use, the specific way that I diagnose it. So,
the broadcast is now starting. All attendees are in listen-only mode.
I'm having trouble with the control. Okay, here we go again. I'm sorry about that. Okay. So one of the first questions had to do with the ALCAT test and normal results that come up on ALCAT when the patient clearly has a reaction to the food. This happens actually quite frequently. And in the case I'll give an example of is the patient who has a clear anaphylaxis to seafood, or a known reaction to something, and most of the time that reaction will have been an IgE reaction. The ALCAT test shows that that food is in the green column and is a safe food to eat. I think it's very important when you look at ALCAT that you understand that it's looking at one part of the immune system. It's looking at the innate immune system. It doesn't look at the IgE or the IgG, which are other components of the immune system. So you can have a reaction with IgE, such as in the case of this anaphylactic reaction, but still come up negative on the ALCAT test. So what I do in my practice is that I use all the information that I have. If I know that the patient has a known reaction, and that food came up negative on ALCAT, I'm going to make an assumption that the patient should still not eat that food. And right when I'm sitting with the patient reviewing their results, I'm crossing that food off right away because there's no question that they are reacting to it. It just was not detected looking at the innate immune system. One of the other questions that arise had to do with food allergies and sensitivities that are noted after the original diagnosis on ALCAT testing. So if you test once and you note sensitivity to certain foods, and then you retest again and you notice that there are new sensitivities, what is the cause of that and why is that happening and what can you do about it? And the question is, is it due to just eating more of those foods after other foods have been eliminated? So, I think this really comes down to the development of new sensitivities. Really comes down to the persistence of leaky gut. If you've not healed the gut, then they're going to continue to react to foods, and they'll continue to react to new foods. I do think that eating allowed foods too frequently also will result in more sensitivity, but it's not that alone. It's really a combination of factors. Obviously, our ever-changing immune system will play some role here, and I can't emphasize enough the importance of stress and the power of stress on development of new sensitivities. And it is so important that that be addressed when you address this issue with patients and you're trying to heal their gut and you're trying to solve the problems that they're having with ALCAT. You need to address stress. And what I do in my practice with every patient who I'm treating, almost every patient that I'm treating, we're talking about how they can manage stress, and we're doing right in the office. We're doing deep breathing exercises, or teaching them a little bit of meditation. Because if I don't help them manage their stress, then they're going to continue having the problems that we're trying to fix. So this was a really good question, because this had to do with how I justified telling people to go off gluten even with a negative ALCAT test. So we had been reviewing in the last webinar that there are times when gluten would come out negative when it's been tested, or even dairy. But I often do tell people that regardless of the ALCAT, I think that gluten may be an issue for them, and I take them off it. So one of the things that I'll mention is that reaction to gluten and its associated proteins occurs on multiple levels of the immune system. And as I mentioned before, the ALCAT does really look at one aspect of the immune system. So it's possible that the reaction to gluten is not detected on ALCAT. But I think that there's more to the story. And of course, gluten is a hot topic right now, and everyone's talking about it, everyone's going off it, but there's a reason. And I'm concerned about the intake of gluten in many people's diets. I'm going to give you just a little bit of background on gluten. Really, gluten entered our human diet somewhere around 10 to 12,000 years ago. So really, that's just a very small part of our evolutionary history. Most northern or aboriginal groups consumed gluten grains for less than a few centuries. So that's very little time for our digestive system, our genomics to adapt. What's interesting is that there are 36 to 43% of the human population have genes that affect the ability to digest grain. That's actually a large percentage. Now, not all those people have celiac disease, but they're certainly at risk for getting celiac disease. And so if you have this large proportion of people who have a gene that doesn't allow them to break down gluten properly, and you start introducing a lot of gluten to their diet, you're going to wind up with more and more people, and that's what we're seeing. I think what's interesting is 90% of some South American and other indigenous people carry those genes. And those are people that really shouldn't be eating gluten and are more and more. Gluten-rich wheat is the most consumed grain worldwide. It's in excess of 600 million metric tons per year, and this is based on 10-year-old numbers. So clearly the number is going to be much higher. 90 million Canadians and Americans, so 20% of the population, are suspected of having non-celiac gluten sensitivity. Now, celiac disease is one form of gluten-related disorders, and there are clearly these non-celiac forms. And 15 experts convened in London in February 2011 to develop a consensus on new nomenclature and classification of gluten-related disorders. And this was groundbreaking. I believe Dr. Fasano was one of those experts, and they discussed the presence of gluten sensitivity without seeing damage done to the villi of the small intestine. And that's important because up until then we've been thinking that really things were pretty much black and white. You either had damage to the villi and had celiac, or you had normal intestines and did not have a gluten sensitivity, and that's clearly not the case. So gluten, to just give you a little bit more background, is a group of storage proteins. It is difficult to digest. It's favorable for the grain itself because it helps with germination and storage, and it just allows the plant to be more robust. So it's found in wheat, rye, and barley. Gluten is very important, particularly when wheat is grown in northern areas. So it is interesting that gluten sensitivity is more widespread amongst northern people. And the polypeptide fractions of wheat gluten protein are divided into two major components. You have gliadin and you have glutenin, and it's based on their solubility in aqueous alcohol. Gliadin is the fraction of wheat proteins that is soluble in alcohol. And this is the prolamin category of proteins. And gliadin is what's really known to inflict the most damage to human intestines. The glutenin is the fraction of wheat proteins that is insoluble in alcohol. It's associated with asthma and autoimmune skin diseases. Some peptides found in gluten, and even casein from milk, look and act like morphine. And this is the other issue surrounding gluten, and the reason why gluten probably should not be included in one's diet. Gluten contains 5 opioids. Now, in particular, there's one opioid that's been studied the most. That's the A5 one. 15 sites of the A5 gluten exorphin in one glutenin protein equals 1 nanomole of morphine. The study was done in the year 2000, looking at, now this was looking at mice, but they showed that there were behavioral, and this is the behavioral and pharmacological studies on gluten exorphin A5, a newly isolated bioactive food protein fragment. Okay, it showed that A5 affected the peripheral and central nervous systems. Gluten exorphins also have an effect on insulin resistance, and it's been shown to increase insulin production and release from the pancreas. This results in blood sugar imbalances and further carbohydrate cravings. So, the question again is, why do I tell people to go off gluten when it's not necessarily showing up on the test? Well, if I'm treating somebody who they're interested in weight loss, or they're interested in curing their migraines, or they're interested in a particular process that we need to cure, then if I don't eliminate the possibility that they're increasing insulin production and release from the pancreas, and they're having more carbohydrate cravings because they continue to eat gluten despite the fact that they've cut out other foods that they're sensitive to, then I'm not going to get anywhere with them, and they're not going to see results. So I think this is important to understand. There was a study done in the Journal of Nutritional Biochemistry, actually just a couple of months ago, in December of 2012. It looked at, this was a gluten-free diet, reduces adiposity, inflammation, and insulin resistance associated with the induction of PPAR-alpha and PPAR-gamma expression. The objective was to assess whether gluten exclusion can prevent adipose tissue expansion and its consequences. So, of course, the study was done in mice. The mice were either fed a high-fat diet containing 4.5% gluten or was gluten-free. And they measured body weight and adiposity. They measured blood lipids and glycemia, insulin resistance. They looked at the expression of PPAR-alpha and gamma, lipoprotein lipase, hormone-sensitive lipase, a number of other insulin receptors, a number of other markers. The gluten-free animals showed a reduction in body weight gain and adiposity without changes in food intake or lipid excretion. And so this is interesting. They showed upregulation of PPAR alpha, which was related to lipolysis and fatty acid oxidation. There was an improvement in glucose homeostasis and pro-inflammatory profile-related overexpression of PPAR gamma. So the data suggested that eliminating gluten from the diet should be tested as a new dietary approach to prevent development of obesity and metabolic syndrome. And I think those of us who treat obesity, metabolic disorders, which I treat every day in my practice, know that unless we look at gluten specifically, we're not going to make a dent. I want to mention, I think this is important for those patients who are putting on gluten-free diets. There may be cross-reactivity with gluten and some of these non-gluten grains. And so, you know, a lot of patients get really excited when you tell them they're going to go on a gluten-free diet, and they were just in the store and they saw aisles and aisles of gluten-free food, and they said, oh, this is going to be great, I'm just going to go and eat that stuff. Well, there may be a problem. So, you know, I discourage patients from replacing their old food with new processed food, of course. But some of the food items that have been shown to have some cross-reactivity include corn, soy, milk, eggs, legumes, yeast, coffee, sesame, and chocolate, even oats, nightshades, and even potatoes. And in particular, corn has been looked at. There's a maize prolamin known as Diamine, which contain amino acid sequences that resemble wheat gluten peptides that may bind even better to the HLA DQ2 and DQ8 molecules that are involved in celiac. And this is obviously very, very concerning. I think the other thing to note is that there are quote-unquote forms of celiac that do not cause damage of the villi, and that really affects the brain and the central and the nervous system, and that could manifest as cerebellar ataxia or gluten-induced neuropathies. So I see that in my practice. I have several patients who have neurologic diseases that are inflicted by gluten without evidence of celiac in their intestines. I'm going to mention this study because this sort of goes back to this concept of cross-reactivity, and also with patients eating non-gluten grains. This looked at transglutaminase treatment of wheat and maize prolamins of bread, which increases the serum IgA reactivity of celiac disease patients. So transglutaminase is one of the enzymes that breaks down gluten, and celiac patients have antibodies against transglutaminase. What is happening more and more is that many companies that are processing breads and making products like that are using microbial transglutaminase. Apparently that helps the consistency of the bread and how it rises, and there are a few factors that microbial transglutaminase are help with, and this seems to be causing a problem. When they looked at, they pooled sera IgA titers from celiac patients, and they exposed them to either patients who had been exposed to wheat or gluten-free grains that have either been treated with transglutaminase or not. And when they looked at that, they found that the IgA titers were higher against the prolamins that were treated with transglutaminase, whether they were wheat or whether they were gluten-free. So again, this is concerning, and definitely speaks to the fact that we need to watch all grains in our diet, probably, if we're sensitive. Another question, so I'm going to go on to some of the other questions that came up from the last webinar. The question was, do you think there's any indication to repeat ALCAT at 60 days? So, you know, the rotation diet based on the ALCAT results really requires each group of food to be eliminated for a certain length of time, with the severe group, the red column, requiring at least a 6-month hiatus. Repeat testing can be confusing for the patient and the practitioner, as there will be movement of food between different columns, and this will necessitate constant diet revisions. So again, my concern is that if you do it too soon, you might see changes, but are those changes relevant? And the other point is that the test is done looking at white blood cells, and white blood cells live for about 6 to 9 months. So I think an accurate test would really be done after 6 months, and 6 to 9 months is probably a good time to repeat. One question that's come up a lot, both through the webinar and in my practice, and actually most recently last week at a conference, I was approached by a doctor asking this exact same question, and that is about the reactivity to herbs that have never been taken or been exposed to. So it seems like, and I have a number of patients who really react to many, many herbs, and again the question is why. And herbs being turmeric, basil, and these I see come up quite a bit, and so it's probably multifactorial. The reactions to herbs or any other food or substance that is ingested can occur even without known prior exposure, and that's the beauty of ALCAT compared to, let's say, IgG testing, because the IgG testing does, to some degree, rely on prior exposure. It's testing the body's reaction to the food, and then you're testing that reaction, whereas the ALCAT is really looking at the innate response, which can happen with or without prior exposure. There's also the possibility that there was prior exposure without the patient realizing it. I mean, even in utero, right, babies are being exposed to food from the mother, molecules of food, and so that is exposure, even if that baby wasn't eating that food after it's born. And I think, the other thing you have to think about in anyone who's having significant reactivity, on the ALCAT is that there has to be underlying immune dysfunction and probably leaky gut. So again, there were many questions regarding the rotation diet specifically, and the question was really related to, how do you initiate a rotation diet, how do you follow it? The rotation diets are all individualized and personalized. There was a question regarding that, whether this is sort of just a general recommendation or is it based on the patient's results, and it absolutely is based on the patient's results. The foods rotate every 4 days, and I think that's important because you might think that a food like broccoli, which may be related to cauliflower but is different than cauliflower, could be eaten on various days. But when you look at the rotation schedule, all the cruciferous vegetables are lumped on one day. So you can eat broccoli, cauliflower, Brussels sprouts, cabbage on one day, but you won't eat that again for 4 days, so that we reduce the reactivity. We are trying to allow for variation, and we want to decrease the risk of developing new sensitivities. And that's important to do. Now, of course, I'm a firm believer in cruciferous vegetables and its effects on so many levels. But in this case, when you're really trying to get at the underlying problem, it is important to follow that rotation diet. There was a question regarding familial tendencies in ALCAT. I take care of a lot of families, and multiple members of those families have done the ALCAT. What I have seen, so some of this is anecdotal, of course, I have seen reactivity to gluten, casein, whey, and eggs frequently occur amongst family members. And for some, that is actually very helpful because if there was a lot of differences between the different family members, it'll be very, very difficult to eat at home because everyone would have to eat different food. That does happen a lot, but there are definitely trends that I see. The degree of reactivity also has a familial tendency, because there is certainly a genetic susceptibility. There's also a genetic susceptibility to leaky gut, which then again leads to food sensitivities. And I think that's probably an environmental factor. The exposure amongst family members may also lead to similar results. Having said that, though, there are definitely cases of families where there are very different results, and again, that is complicated. There was a question regarding one of my case studies from the webinar, the last webinar, and it had to do with T3. That patient had low T3, before implementing the ALCAT. And the question is, was it retested? Did it improve? How long would it take for T3 to improve with dietary changes, et cetera? And I think this is a good question because I think T3, low T3 and thyroid disease in general is becoming more prevalent, and we're all seeing it in our practice. And ALCAT, I think, can be very helpful in addressing that issue. I know some of you have obviously, listened to the first webinar, but I want to go through that case briefly so that you get an idea of what happened and how, again, ALCAT helps. So this was a 65-year-old female who presented with a history of irritable bowel, migraines, prediabetes. She had some peripheral neuropathy. She had suspected food intolerances to milk and dairy for years. She had anaphylaxis to scallops. She had seasonal allergies and asthma. She had recent alopecia and weight gain, and she had osteoporosis. So she was a typical patient. She was treated for years with metformin, topiramate for migraines, triptans for migraines. She was on montelukast for asthma and allergies, and inhaled steroids and proton pump inhibitor, worst of all. And so she had recently gone on a gluten-free diet after several family members were found to have a sensitivity to gluten. But there was no family history of celiac, and she did report an improvement in her symptoms on a gluten-free diet, but unfortunately it was short-lived. And her symptoms returned after a few months. And the symptoms she was most concerned about was alopecia and weight gain. So she tried a dairy-free diet based on the assumption that she always had suspected a dairy sensitivity, or what she called lactose intolerance. But she had continued to consume these foods for years, thinking that she was just lactose intolerant. But she decided to go off of dairy, and again saw the same improvement after several weeks. But then her symptoms returned. So at that point, she saw me. When we put her through some testing, and we did some thyroid evaluations and looked at her insulin resistance and vitamin levels. And she really opted not to do any food sensitivity testing due to cost. So it was very clear that even on metformin, she still had prediabetes. Her TSH was elevated at 2.86. She had a free T4 of 1, a free T3 of 2.5, which were low thyroid hormones and elevated TSH. She had normal thyroid antibodies. She had elevated cholesterol. She had very low ferritin levels and a low B12. She had a colonoscopy. She didn't have colon cancer, but she was clearly iron deficient, and she was also B12 deficient. She had a prior history of vitamin D deficiency, but it was on supplementation. So at that point, we started what I would call a paleo diet. It was a low-carb, high-fat protein diet. I started her on Armour. She got some activated B vitamins, including methyl B12, and we couldn't supplement iron due to some side effects. She got high-dose probiotics at 100 billion units, and a few other supplements. And she definitely improved. Her hair stopped falling out. She lost a few pounds. Her TSH levels started to improve. Her lipids started to improve. But she was not 100%. So we decided to do the ALCAT. She decided to go forward with the testing, and we did. And what we found was very interesting. In her severe intolerance column, she was noted to be intolerant to quinoa, garlic, and haddock. Now, quinoa was interesting to me and to her because going gluten-free encouraged her to eat more quinoa. And so she was eating a lot of quinoa at that time, and clearly wasn't helping. She had some moderate intolerances, and quite a few, and I highlighted the ones that she really also was eating a lot of or had been part of her diet for a long time. Buckwheat, she was from Eastern Europe, and so she kind of grew up on buckwheat. Flaxseed, kelp, pear, turkey, a few of the things that she enjoyed eating. And some things that she rarely ate came up as well. She had mild intolerance to a lot of foods as well. And she definitely showed a mild reaction to gluten. Now, she had been off of gluten for a number of years at this point, but she continues to show a reaction. She definitely had a reaction to whey, but interestingly not to casein. So we put her on, we eliminated all the reactive foods. We put her on a 4-day rotation diet. And at follow-up, she had her IBS suddenly started to subside, and that was after many years of suffering. At 1 month, her bowel symptoms were completely resolved. After 1 month, she did try adding her yellow foods back in a 4-day rotation, and she noticed, though, that there were still some foods that were causing some symptoms, so she continues to avoid those, and she still continues to be gluten dairy-free. She did lose 10 pounds in 4 weeks. Her migraines were improved, and although they came back when she cheated once. But here's the important information. This is where the thyroid comes in. So 3 months after being on Armour and ALCAT, on that ALCAT rotation diet, her TSH went to 0.52, and it previously was well over 2.6, and then was 2.12 at a repeat prior. So the numbers you saw previously was the initial, then there was another evaluation, and then this was 3 months later. Her T4 went to 1.2, and her free T3 went to 3.5, and prior to that was 2.8. Her reverse T3 started at 14 and unfortunately was not repeated. I want to mention that, again, she had true hypothyroidism, and she did have a family history as well, but what I'm seeing a lot is low T3 syndrome, which is Wilson's disease. And this should be treated, and the aim should be to reduce stress. You need to treat the adrenals, eliminate food sensitivities, treat the leaky gut, and potentially supplement with T3 if the T3 numbers are not coming up. So typically we're seeing T3 numbers starting to rise 3 to 6 months after ALCAT, plus additional treatment of the adrenals, etc. So 3 to 6 months is a good time to sort of evaluate, look, and then if it's not getting better, consider being more aggressive. So again, one of the questions that came up also had to do with when to use the ALCAT. So I think there's some traditional diseases that are thought of to be useful to use ALCAT in, such as migraines, irritable bowel, but there clearly are a number of disease states that I think can be very useful in. A lot of these I've used them in myself. So dermatologic conditions, eczema, psoriasis, I think that's maybe obvious, but granuloma annulare, which is a rash that develops in diabetics, however, can definitely develop in patients with insulin resistance. I see this quite often. They're not diabetic, but they're insulin resistant, and they develop this rash. When you improve their insulin resistance, the rash goes away. Often, if you don't attack the underlying food sensitivities and the other causes of insulin resistance, the rash doesn't improve. So ALCAT can be very helpful in getting to the root of the problem. Obviously, autoimmune disease can be very useful for arthritis, abnormal liver function without obvious liver disease, neurologic conditions, as I mentioned, migraines, ataxia, and cerebrovascular accidents such as stroke. So lastly, the area that people were most interested in had to do with leaky gut. And what I'm going to do is I'm going to spend some time talking about the diagnosis and how I go about doing that, and then looking at my protocol. So when I'm thinking about leaky gut, I'm obviously looking at ALCAT and looking at their food sensitivities. I might be interested in their IgE if I know that they have allergies as well. I might be interested in IgG depending on the answers I get. So I'm getting a full picture here, again, of the underlying their underlying immune system. I'm also interested in zonulin. Now, zonulin is a protein that causes the assembly of tight gap junctions and increased permeability within the intestines. Increased levels of zonulin may contribute to the development of celiac disease, autoimmune disorders, insulin-dependent diabetes, multiple sclerosis, and rheumatoid arthritis. And there is a test, and there are probably a number of labs now that are starting to test for zonulin. And I'm just going to go forward here and just show you a schematic from the clinical practice of gastroenterology and hepatology. And this was also by Lucio Fasano. And I don't have a pointer, but if you look to the far right of the drawing, you will see green round balls, and there's a arrow pointing to it, and it says zonulin. And that zonulin protein is binding to receptor sites in the intestines. And as you can see there, where the number 3 is pointing down, there is starting to become a separation of the intestines. That's increasing the permeability, and that's what zonulin does. So zonulin can definitely be a marker for gut permeability. Another thing that I'll often check for is I'll do some stool studies. I'll look at secretory IgA because low levels are consistent with leaky gut. I'll look at if there are underlying parasites, yeast, or other opportunistic infections, because if you don't treat the infections, the leaky gut persists. A mannitol lactulose test might be useful to look at the placebo, small intestinal bowel overgrowth, and this is definitely an important issue because I think there are many people who are symptomatic who continue to have leaky gut and other symptoms, and this needs to be treated. I'll look at nutrients. I'll look for malabsorption. I might do organic acid testing. So my approach to leaky gut is, first I'll start. We start with the ALCAT. We follow the rotation diet. We remove any food allergens. I think that's very important. And then I'm looking at the stool test, and I'm looking at if there are offending pathogens. And I might treat with medications. They may need an antifungal like fluconazole. They may need a metronidazole for bacteria. They may need rifaximin. Rifaximin is a non-absorbable antibiotic. It can be very useful in treatment of SIBO, small intestine bowel overgrowth. There are a number of herbal and natural remedies that can be helpful as well. And again, depending on the results, depending on the severity of the symptoms, I might use something like berberine or colloidal silver. Colloidal silver is an antimicrobial that has been shown to have activity against yeast, parasites, and bacteria. There's one product that I use frequently in my office called Argentin 23, and that is that I've used with a number of different infections, including Lyme. Wormwood is another helpful herb. The other thing that when you're thinking about treating leaky gut, you also need to look at histamine. And in particular, you need to increase an enzyme called Diamine oxidase. Now, this is an enzyme that degrades histamine. And it's been shown that histamine in itself can lead to leaky gut. So if you have an insufficiency in this enzyme, it's going to lead potentially to an additional problem with this leaky gut situation. This is a study coming out of the American Journal of Clinical Nutrition in 2007. And this looked at histamine and the enzyme diamine oxidase and its effects on overall health and reactions. I'm sorry. Besides headache, gastrointestinal ailments, including diffuse stomachache, colic, flatulence, and diarrhea, are leading symptoms of histamine intolerance. Elevated histamine concentrations and diminished DAO activities have been shown for various inflammatory and neoplastic diseases such as Crohn's, ulcerative colitis, allergic enteropathy, food allergy, and colorectal neoplasms. This was a study looking at rats. This was done in 1980, so you know that this information has been around for a long time, but unfortunately hasn't been really addressed as much as it probably should be. One of the things that this showed is that with increasing mucosal damage, there was a progressive decrease in the enzyme activity. So first lactase levels fell, then maltase and sucrase, and finally mucosal and plasma diamine oxidase activities level fell. What they found was that plasma levels of diamine oxidase correlated with mucosal levels of diamine oxidase, and that if you measured in the plasma, you could get a very good sense of mucosal maturation and integrity. So measuring diamine oxidase can be helpful in understanding whether there's a leaky gut and what other treatments can be implemented. Let me go through that slide. So histamine is released from mast cells. Histamine can also be ingested. And either form could potentially lead to tight junctions to degrade, so that permeability. Now, the foods that are high in histamine include tomatoes, chocolate, aged cheeses, tuna, fermented vegetables. Foods that induce the release of histamine include sunflower seeds, citrus, buckwheat, strawberries, nuts, and vinegar. And then there's another layer, and these are foods that are high in competitive amines that saturate the diamine oxidase enzyme, making it less effective. And that's things like chocolate, orange, tomato, avocado, nuts, and beer. And then there are many medications that inhibit DAO, and namely antibiotics, specifically cephalosporins, have been shown to decrease this enzyme in the gut. So if there's less of this enzyme in the gut, you have increased histamine, you have increased permeability. So you need to increase the amount of diamine oxidase in the gut. And you can do that through fish oil, which helps the body produce more DAO, B6, vitamin B6, which is a cofactor for the production of diamine oxidase, and you need to treat adrenal fatigue, which clearly plays a role in this as well. There is a supplement available called Hist-DAO, and it's produced by Zymogen. And the way I'll dose it is I'll give it 15 minutes or less prior to a meal, and with each meal, even if that meal is not necessarily high in histamine, especially if I'm trying to treat a leaky gut, I might do that for 3 to 6 months, especially if I think that this is a possible cause of their leaky gut. There is a test for diamine oxidase and histamine as well. Again, so these can be measured in the blood. Some of the other things that I'll use in my protocol, I often use glutamine in doses somewhere between 4,000 and 10,000. I'll use aloe, both, and there are pill forms that are available, there are liquid forms that are available. I'll use immunoglobulin therapy. There are a number of products that are available. Zymogen makes a IgG 2000, which has a number of immunoglobulins, including IgG. And this helps to provide protection against infection, but also blocks zonulin's effect on intestinal permeability. So I think this is an important treatment. Digestive enzymes, important again, because as the gut increases permeability, you are decreasing the number of digestive enzymes present, and you need to supplement that. Probiotics are obviously very, very important. I get asked very often, what brands I'm using and how much. Claire Labs makes a complete probiotic, which is 25 billion per capsule. They have a powder that is, if you use a half a teaspoon, it's 100 billion. So depending on, again, the dose I'm thinking about for the patient, I'm using a powder, I'm using a pill form. I have my own probiotic, Optimum Probiotic, which is similar. Orthomolecular makes a 225 billion unit. So I'm approaching it, how much I'm treating them with, based on what they're on already. So if I know that they've been taking probiotics and they still have a leaky gut, I'm obviously going to use a much higher dosage for a short period of time, and then I'm going to figure out what their maintenance dosage is. Saccharomyces boulardii is important because it decreases zonulin. It competes with Candida, and so if there's a yeast overgrowth issue, you're going to prevent adhesion, and it reduces cytokine-mediated host response. Arabinogalactan is a polysaccharide derived from larch tree, and it's a prebiotic. It's a non-digestible, soluble dietary fiber. It helps to stimulate the growth of beneficial bacteria in the gut. It may reduce intestinal ammonia also, which can have a damaging effect on intestinal walls and lead to leaky gut. There's a product that combines arabinogalactan with, let me go back, with glutamine and aloe, and that's called glutalamine, and that's made by Zymogen. It's in a powder form. There's some research looking at novel zonulin antagonists, and I think that's on the horizon as well. And that may be something that's going to be used to either prevent celiac or to prevent food sensitivities or other issues. So I'll end with a a funny food allergy little cartoon. Food allergy side effects may include healthier eating habits, improved baking skills, and an increased number of meals together at the dinner table. And so again, this is talking about food allergies, but it might as well say food sensitivities. This is obviously important. It's impacting our health. We're seeing more and more chronic disease in this country, in this world. And when we start looking at what we're putting in our body, we're going to impact everybody, including our children. So I will end on that and see if there are any questions. Hello? Hello? Make sure someone's still there.
Dr. Dempsey, can you hear us?
I can now.
Okay, we got a couple questions. Hi, it's Lee over here, Dr. Dempsey.
Okay.
One of the questions earlier regarding coconut, they were asking, does that include the coconut meat, coconut oil, and coconut water?
I do believe it does, and that's how I approach it. So when coconut comes up, we're eliminating all aspects of the coconut for whatever period of time is needed based on where the coconut falls in that chart, and then it can be reintroduced. I would probably reintroduce coconut oil first, if I was going to reintroduce it, followed by coconut milk and then other coconut products.
Thanks, Dr. Dempsey. Another question that came in was, are your protocols and dosages for children different than your protocols and dosages for adults?
Yeah, and they have to be for a number of reasons. Obviously, with children, I always have an issue with getting the stuff into them. So, some kids will take various powder forms and, various chewable forms of stuff, and I'm always looking for other ways to get those supplements into the kids. So it will differ in that regard. And yeah, some of the dosages obviously will be different. Probiotics, I might use more on the 25 maybe to 50 billion range with kids, but I've certainly gone up to 100 billion in kids as well on the probiotic range. But again, the issue really is trying to figure out what the underlying problem is and figuring out. I'm not going to use all those things in every single person. I went through some of the things that I'm using, but again, I have to individualize it for the patient. So for the kids, probiotics are going to be like the #1 thing because that's the easiest thing for me to get into them. I'm going to work on the foods. And then I'm going to think about what else they need. I'm going to supplement things that I know that they're deficient in. So if they're having malabsorption, the first thing I'm thinking about is just giving them stuff because I don't want them to suffer from the nutritional deficiency. And then in thinking about how I'm going to treat their gut, if I can, get them something like IgG 2000. It does come in a powder form. The problem is it's very hard to get the kids sometimes to drink things that are, been dissolved, and it looks funny to them, and so it's challenging. But it's been done. I've done it, and you just have to work on it. But yes, the answer is the dosages and the protocol does change somewhat. The underlying problem is usually the same.
Thank you, Dr. Dempsey. I got 2 more questions here for you. The first one would be, does every patient with gluten sensitivity need to be tested for celiac?
Yeah, that's a great question. I screen everybody. Right now, that's my practice. I'll screen everybody for celiac in the blood. A large percentage of patients who are gluten intolerant will have no evidence of anything in the blood. Occasionally, I'll see elevated gliadin antibody, IgG or IgA, and that will, maybe point me closer to that answer that they're definitely gluten intolerant. Not necessarily celiac, obviously, but I'm doing celiac screening on everybody. You're going to miss some cases of celiac that way. The gold standard is an intestinal biopsy. So I think with each patient you have to understand, what you have to think about what the chances are that they have celiac. If there's a big high suspicion that they have celiac and they're very symptomatic, before you take them off gluten, you might want to consider doing more extensive testing if the regular testing was negative. And that's because I think there are a number of reasons. Number one, having celiac increases the risk of certain types of cancers and other diseases. So you need to know that information. On the other hand, if it really seems like a gluten intolerant situation and they're doing well on a gluten-free diet and they don't want to go off a gluten-free diet for further testing, then I think it's safe to just continue the gluten-free diet and end the testing there. So this is a really case-by-case.
Fair enough. Thank you, Dr. Dempsey.
Yeah.
The last question, and I can answer this one with you and for you. Olive sensitivity, does this include olive oil?
Oh, I'm sorry, I didn't hear the question. Can you repeat that?
For olive sensitivity, does this include olive oil? And the answer is of course. And the answer is absolutely.
Yeah, yeah. And that's a tough one when that one comes up, because olive oil is just in about everything, and lots of people cook with it. So when that comes up, you have to find alternative sources of oils.
Yep. And then a couple people have had the question regarding the slides or copies of the presentations, and those will be archived on our website for future viewing should anybody want to review the presentation or see it again in its entirety. So that'll be on ALCAT.com, www.alcat.com very shortly, and there'll be archived versions of this webinar as well as all the past webinars done by other practitioners as well.
Great.
Dr. Dempsey, thank you as always.
Oh, it's my pleasure. Thank you so much for having me today.
Thank you, Dr. Dempsey. Have a good night, everybody.
Thank you.